My name's Thomas Hunter, I'm one of the orthopaedic consultants here at Wrexham. Here we have a selection of short videos for information for patients who are coming for their joint replacement surgery. We know this can be quite a daunting time for patients, so we've tried to get as much information as we can for all the different aspects of staying in hospital for your operation, as well as what happens afterwards. And I'm going to give a short talk now about what to expect if you're coming along to have a hip or knee replacement operation done. So the learning objectives we have to look at what is arthritis, how we prepare for surgery, what to expect when you're in hospital and then at home afterwards, and also the roles of other things such as physiotherapy. When we look at hip arthritis, the hip is a ball and socket joint that has a covering of cartilage over the ball and the socket. As time goes on, and for various other reasons, that cartilage can wear away until you end up with bone against bone, which can be very debilitating, can cause pain, and also stiffness of the hip. It can interfere with somebody's quality of life quite substantially. Knee arthritis is a similar picture. We normally have a cartilage that covers the bottom of the thigh bone and the top of the shin bone. For various reasons, again, this can wear away, ending with bone rubbing against bone, causing significant stiffness and loss of function and pain. When we talk about joint replacement surgery, we want to surgically expose the damaged joint. The arthritic bone is then removed. We implant an artificial joint, and following this the wound is closed and the dressing is applied. Here we have an example of a typical hip replacement prosthesis. So it comes in a number of components. We have a stem that sits down the middle of the thigh bone. On top of that sits a ball, and then on the other side of the joint where the socket is, we have a shell that sits inside your existing socket, and then inside that we have a liner as well. When we look at a knee replacement, we cover the end of the thigh bone with prosthesis, and then at the top of the shin bone there's a metal tray with a plastic liner that sits on top of that. When it comes to implant choices, there's quite a bit of variety. Broadly, they can be cemented or uncemented for a hip and knee replacement. Which implant is used will depend on surgeon preference, what they've trained with, and what they feel is the most appropriate implant for a particular patient to have. When we talk about a bearing surface, these are the surfaces that touch against each other within the joint. Typically in a knee replacement, this is the metal part at the end of the thigh bone and the plastic block that sits on top of the metal tray. When it comes to hip replacements, the ball of the hip joint would typically be metal or ceramic, and that would be against a plastic liner within the metal shell as we saw previously on the picture. So how do you prepare for the operation? It's important to avoid any infections, as they can risk getting an infection into the new joint replacement. It's important to make sure that dental health is optimised prior to an operation, as it's very easy for infections in the mouth or teeth to travel through the blood and get into a newly implanted joint. It's important to stay as active as possible prior to your operation, as building your muscles up before the operation will mean that you're able to get up and about faster after the operation. It's important to optimise weight prior to a procedure. If you suffer with diabetes, it's very important to make sure this is well controlled, as uncontrolled diabetes can lead to problems with wound complications and infections. It's important to keep the skin on the operated limb clear of any cuts, bruises or insect bites, as these can lead to an increased risk of infection. It's important to follow any advice you've been given on stopping any medications prior to your operation. And it's very important to make sure you have adequate support from friends or family at home after your operation. If you're a smoker, it's vitally important to try and reduce or ideally stop this, as smoking increases risk of infection and wound healing problems. And it's important to learn and practice the exercises you'll be informed about to undertake post-operatively. On the day of surgery, you'll arrive at a designated time. You'll be admitted by the ward staff, and they will undertake a theatre checklist with you. You'll then be seen by the surgical team, where they will recheck your consent, and you should have the limb marked with an arrow. You'll also be seen by the anaesthetic team for a discussion regarding the anaesthetic options available. After the operation, when it comes to care of the wound, there'll be a sterile dressing applied. We try to minimise the number of dressing changes to minimise the risk of infection. With a knee replacement, patients will often have quite a large compression bandage in place, which will be reduced usually the day following surgery. If clips or sutures are used, then they often removed at 2 weeks. And we have an excellent district nurse team that will often see patients at home to check wounds and liaise with us regarding any problems. When it comes to discharge, most patients are discharged 1 or 2 days after their operation. You'll have a post-operative X-ray in the hospital, which is routine. When you're discharged depends on how good you are with your mobility, your pain control and the exercises. The important thing is to make sure that you're safe to go home and that you're going to be able to cope. Most patients are discharged directly to home. Occasionally, patients may need a package of care at home, or very rarely admission to a community or rehabilitation hospital for some extra support before going home. After you're discharged, you'll be followed up usually at the 4 to 6 week mark with somebody from the surgical team. You may be offered a follow-up appointment at 1 year after surgery. You will often be contacted via the post with patient surveys, and follow-up x-rays will be arranged in due course, normally at the 1 year mark and then subsequently after that. Patients may well attend physiotherapy clinics for a bit of extra support as well. When it comes to resuming activities, most patients are keen to find out when they can return to driving. There's no set time for this. It's whenever you feel safe to drive again. It's generally 6 weeks following the operation. When it comes to resuming sports and hobbies, this is usually when you feel able to do so, but generally at least 6 weeks for gentle activities, but can be 3 months or more for more vigorous activities. Thank you for listening to the presentation, and we hope to welcome you to the ward soon.
Hello, I'm Dr. Fiona Nelhans, and I'm one of the group of orthopaedic anaesthetists at the Wrexham Hospital. I've been asked to do just a quick overview of what to expect from your anaesthetic for your hip or knee replacement surgery. So what are we going to cover? I'll have a chat about the anaesthetist visiting you in the morning or day of your surgery. We'll have a look at your anaesthetic choices, and we'll go through pain relief during and after the surgery. On the day that you come into hospital, your anaesthetist will come and visit you on the ward. There will always be a senior anaesthetist in charge of your list. They may have a trainee with them. One of those two will come and see you beforehand. The main focus of the visit will be discussing your medical history and any medical conditions you may have and how they affect you in particular. From that, the anaesthetist will be able to make a judgment as to which form of anaesthetic may be more suitable for you. They'll have a look at the medications that you're normally on and discuss which ones you have taken that day. And then we will discuss with you which anaesthetic is best for you and what will happen when you get to the theatre suite. Basically, you have two choices. We have a general anaesthetic or a spinal anaesthetic, and we'll look at each of these two in a little bit more detail now. So a general anaesthetic is what people tend to expect when coming into hospital for an operation, that they go off to sleep, they're sound asleep for the operation, and then wake up again when it's finished. The advantages of that is that you will be unconscious for the whole of the operation. Disadvantages, though, are you may feel sick afterwards. Again, that can be treated with anti-sickness medication. You may have a sore throat afterwards. That can be treated with pain relief drugs. You may be more prone to a chest infection afterwards, which can be treated, but all of these things may delay your recovery. Spinal anaesthetic, this tends to be the preferred choice for this procedure. In excess of 90% of hip and knee replacements are done with a spinal anaesthetic these days. Your anaesthetist on the day will go into more detail with you of what's involved, but essentially a spinal anaesthetic is an injection that goes into your back, and it will make your legs numb and heavy for up to 3 hours so that you will feel no pain during the procedure, and the procedure can be done entirely this way. You can either stay awake during the procedure, or if you prefer to, you may have some sedation during that time. If you opt for a spinal anaesthetic, I will explain briefly what happens, though your anaesthetist will go into more detail on the day. When you come to theatre, you'll have all the routine monitoring put on, and you will have a drip inserted. The anaesthetist will then go and wash their hands, while the anaesthetic assistant will position you usually as the illustration on the right here. So you'll be sat on the operating table in the anaesthetic room with your feet on a stool. Main difference being, you won't be stripped off as this patient is, you will still have your gown on and be covered. The skin will then be cleaned with some cold spray. There will be a sharp scratch and a little bit of stinging while some local anaesthetic is put into the skin. Then the block is inserted. First thing you usually feel after that goes in is that your bottom gets warm or your toes get tingly, and then they'll position you back round onto the table. So the advantages of the spinal anaesthetic compared to the general anaesthetic is you remain in control of your breathing and your cardiac function to a great extent, which means that you will be breathing for yourself throughout the procedure and will breathe better in the first few hours after your anaesthetic. This means that you'll be less likely to develop a chest infection. You will be more comfortable immediately after the operation in the recovery area. There's a reduced incidence of blood clots in the legs and therefore blood clots that travel to the lungs. You'll be less sick and drowsy after the operation, and you'll be able to eat and drink sooner. In fact, the vast majority of our patients who have their surgery done with a spinal anaesthetic are able to have a drink of water in recovery. Like anything, there are some disadvantages with the spinal anaesthetic. Your legs will feel heavy for the duration of the block. So for that 3 hours while the block is working, you may well not be able to move them. There is an increased risk of being unable to pass urine freely afterwards for a few hours, so you may temporarily need a catheter. Because of the way that the spinal anaesthetic is inserted, there is about a 1 in 150 risk of having a headache afterwards, and there is a 1 in 25,000 risk of having some nerve damage. If this is something that concerns you, then your anaesthetist can go into this in greater detail on the morning of your surgery. So the anaesthetist, after taking your medical history, looking at your drugs, will have a discussion with you and make a recommendation as to the type of anaesthetic that they feel would be best for you. At the end of the day, the choice of anaesthetic is yours. The anaesthetist will never force you to have one form of anaesthetic over the other. They may strongly recommend one because of something in your history, but generally, if they are happy that you have understood the implications and the risks, they will go with your wishes. So the anaesthetic visit on the day of surgery is a good time to ask questions of the anaesthetist and to express any concerns that you may have. Very, very occasionally, we may have to delay your operation. This is usually done after pre-op before you get into hospital. But if something has changed between your pre-op visit and you coming into hospital with your health, or if you are acutely unwell with something, it may be that your surgery has to be postponed. That will only happen if we feel there is something that can be done to improve your health, or if we feel that you have such high risk, you need a bit more time to consider whether you wish to proceed with the surgery or not. So thinking about pain relief after surgery for hip and knee replacement. There are various methods of treating the pain after your surgery. We can include some simple but significant measures, such as non-drug measures, which may include positioning, so something as simple as a pillow under your knee if you've had a knee replacement surgery, or the use of ice packs. We can also use, obviously, some drug methods. So these can include local anaesthetic, which will usually be administered at the time of your surgery. Afterwards, back on the ward, there are various drugs we can use. So we will use these in combination. They include drugs like opioids, anti-inflammatory drugs and their subclass, the COX-2 inhibitors, paracetamol, occasionally some convulsant drugs such as pregabalin and some antidepressant drugs, though those are used less these days. Patients will be prescribed regular paracetamol to be given at set times on the drug ward rounds. You will also be prescribed medication from the next rung up, so the stronger pain relief, which is usually opioids. Some anaesthetists and some surgeons prefer that you are prescribed modified release medications of this twice a day, with additional prescribed for what we call breakthrough pain, so as and when you need it, you can request it. Some anaesthetists will prescribe opiates as a modified release preparation, so it will be prescribed twice a day, with additional faster acting prescribed for as and when you need it, so you can ask the nursing staff for that. You will also be prescribed a regular anti-inflammatory drug unless you are unable to tolerate these. Patient-controlled analgesia, or PCA, is a form of pain relief that is rarely used today because it comes with some quite serious side effects and also limits the ability to mobilise early, which obviously is something that we are keen for you to do. So side effects of the analgesics occur mainly with the opiates, the strong painkillers, and can include nausea and vomiting and constipation. We can and will prescribe drugs to counteract those effects if you have them. Patients who have not previously had opiate drugs, so are not used to codeine or other medications like that, may find that it makes them drowsy, and in some rare cases it can produce hallucinations. If you have any of these side effects, inform the nursing staff. You can be given drugs to counteract the side effects, or the drug can be changed. At your anaesthetic visit on the day of your surgery, your anaesthetist may also inform you that they will administer a nerve block along with either your general or spinal anaesthetic. A nerve block is where local anaesthetic is deposited close to some of the nerves that supply the joint that is being operated on. They may help pain relief, but they don't usually provide complete pain relief, and they may or may not be appropriate for all procedures. Your anaesthetist will inform you beforehand if they intend to carry out one of these blocks. All patients will have local infiltration at the time of their surgery, so the surgeon will administer this around the hip or the knee joint. It will give pain relief that can last for up to 8 hours and is much more commonly used than nerve blocks. So after your anaesthetic visit in the morning, when you're ready to come to theatre, you'll be escorted down there into the anaesthetic room. In the anaesthetic room, you'll be met by your anaesthetist and your anaesthetic assistants. Once you have your monitoring on and you have a cannula in place, there will then be further safety checks completed to ensure that we have the right patient, the right operation. Your general or spinal anaesthetic will then be administered, and the important thing to remember is the anaesthetist will be with you throughout. You don't have to remember everything you've been told from the anaesthetic visit earlier in the day. All instructions will be reiterated to you. Once the anaesthetist is happy that you're under general anaesthetic or that your spinal anaesthetic is working, you will then be wheeled into theatre. Obviously, you will either be awake or asleep, depending on whether you have chosen to have sedation or not. The anaesthetist will always be with you. Surgeons are fully covered at all times to avoid infection, and you will be covered as far as possible according to your surgical site to preserve your dignity. If you choose to be awake, there will be a screen in place so that you do not have to see what's going on. And if you have sedation, you are unlikely to hear any of the noises. At the end of your procedure, you will go into the recovery area where the nursing staff will continue to monitor you for your heart rate, your blood pressure, your oxygen saturations. If necessary, they can administer some more pain relief for you. If you've had a spinal anaesthetic, you may even be able to have a drink of water at that point. They will check your dressings and check your wounds, and then when they're happy that everything is settled, they will send you back to the ward. After surgery, you can eat and drink normally, and you will be encouraged to do so. The nursing staff on the ward will continue to monitor your heart rate, your blood pressure, your oxygen levels. You will probably have calf pumps on your leg, which will go up periodically to aid the circulation and try and prevent blood clots. Deep breathing is encouraged. You will be given foot and ankle exercises by the physiotherapists. If you've had a knee replacement, you may be asked to start bending your knee. You will be mobilised as early as possible and given physiotherapy. So the key things for success, as I said, eat and drink early and try and exercise and mobilise as early as you can. Keep on top of your pain by taking the regular analgesia and asking for the additional analgesia as you feel necessary. You don't get any extra brownie points for suffering. Mobilise early, and hopefully all of these measures will lead to early discharge, because we know patients recover better at home than they do in hospital. So finally, the thing to remember, you're coming into hospital well, you are well before surgery, and the important thing to do is to take charge of your anaesthetic and your recovery. Thank you.
My name's Colin. I'm one of the nurses on the orthopaedic elective ward, and I split my time between the ward and joint school. I'll go through what you can expect when you arrive on the ward, ready for your surgery, and I'll go through the process from being admitted into being discharged home. So you'll be admitted for joint replacement surgery. Admission to the elective ward, what we ask you to do is to bring in all of your medication. We do need them in their original boxes, and if you can bring in 7 days supply, it's just so as we can check that you've got the correct medication with you. Clothing for a couple of days. If you're having a knee replacement, shorts and t-shirts are excellent. Something that's light and loose, and any toiletries that you may need. You'll be given relevant staffing instructions prior to your admission, and they do ask for you to have a shower or a bath the evening or the morning of your surgery. When you do arrive, once the paperwork has been completed, they'll ask you to get into a theatre gown, and then we'll wait for the theatre suite to give us a call. We will check your temperature, blood pressure, your breathing rate, all things that we class as observations, just to get as a baseline for you. Blood test, they will be done when you arrive, and one of the consultants will put a pen mark on your leg. Once you're ready for theatre, the anaesthetist will come and see you, go through their checklist as the nursing staff will have gone through theirs, and then a member of the team will escort you to theatre. How you get there is entirely up to you. The theatre suite is about a minute's walk away from the ward. A lot of people walk simply because they can and they prefer that rather than go down in a chair. But if you do need assistance getting to theatre, just let the ward staff know and they'll arrange a chair to get you there. Safety checks are done prior to going to theatre. So what we do is we check that you've signed a consent form for the correct leg, and your consent form is correct and all the documentation supports that. We do all the checks on the ward. The surgeon will quite often come and put a pen mark on your leg with the initials THR or TKR for total hip or total knee replacement. And then when you get to theatre, one of the theatre staff will again check your consent form and make sure that the pen mark is on the correct leg. And then they quite often do it again in the anaesthetic room. In the reception part of theatre, you will be met by one of the recovery nurses. That nurse is assigned to your care during your time in theatre. The nurse will follow you through your surgery to recovery, and the whole idea is waking up to the same nurse. It makes people feel a bit more at ease. So this is one of our theatre suite. Around the roof there is a glass cage, and that's part of an air filtration system, and it scrubs the air entering theatre. Air flows one way, and it's all designed to reduce the risk of infection. We like to maintain dignity as much as we possibly can. False teeth, wigs, hearing aids, they can all be worn to theatre. If and when they need to be removed, they are in the anaesthetic room and then given back to you as soon as you go into recovery. And it is the responsibility of the doctors and the nurses in theatre to maintain your dignity at all times. After your operation, you go into recovery, and they do quite close monitoring in there. It's quite commonplace. It's quite a large room. There may be more than yourself in there being recovered. So you hear lots of chatting going on, but it's all designed to keep you at ease. They will check your blood pressure, the oxygen levels in your blood, and also your temperature. You're never left on your own, and they're ideally placed to give you some extra medication should you need it. You will feel some pain after this surgery. Once the anaesthetist is happy with your recovery, then you are able to leave the theatre suite and return to the ward. The theatre staff will hand over to the day staff, the ward staff, and then they will take over your care. We will regularly check your blood pressure, your pulse, temperature, your breathing, and again, like I said earlier, what we refer to as observations. Once on the wards, we'll encourage you to repositioning, deep breathing, foot, ankle exercises, just to help with the blood flow in your operated leg. It helps to prevent things like blood clots and pressure sores on your heels as well. Passing urine, if that is an issue, you can't get to the bathroom, we've got urinals or commodes that we can use. We very rarely need to use catheters because they're a risk of infection. They're usually the last resort. We do try to get you to the bathroom though. Sometimes people feel a little bit faint and a bit nauseous when they come back from theatre, but that's relatively normal. That's what we expect. And there's medication that we can give to alleviate that. We also like to give you extra tablets after your operations, so things like laxatives because you are prone to constipation, and antiemetics if you're feeling a bit nauseated. And your consultant will come and see you, and ideally, if you're having a knee replacement, they like you to be up after 2 hours and a hip replacement after 4 hours. So day one after surgery, a wash at the bedside, or if you're feeling okay, we'll get you through to the bathroom. Breakfast is usually quite early in the morning, about 7:30. We'll get rid of all your attachments, so your blood pressure cuff, the finger probe for the oxygen levels, anything that can be a trip hazard, we tend to move out of the way just to maintain your safety. Pain relief drugs around will normally come around about 8 o'clock in the morning. But if you need any pain relief before that, just let the staff know because there should be something that you can take. And then it's up in the chair. We'll continue to check your observations. We do them quite regularly. The consultant will come and have a chat with you to let you know how theatre's gone. You'll have blood tests and an x-ray during that day. And then you'll be encouraged to mobilise with the nurses and the physios and to do your exercises that you'll have been shown. On day 2, again, it's pretty much a rerun of day 1, up and washed in the bathroom, dressed and breakfast, continue to practice your exercises with the physios and with the nurses. Walking will increase the distance and they'll offer you stair practice as well. We'll keep an eye on your wound. Knees are quite easy because we can see them. Hips are a little bit more private, but we just need to make sure that the dressing's clean and dry. Continue to do your observations, and there's certain blood tests that we might need to repeat on day 2, but not always. And then day 3 is day of discharge. You'll be discharged from hospital when the team are happy with your progress. So we need the physio to let us know that you're safe. We need the occupational therapist to tell us that you've got all of your equipment, and then the nursing staff will notify you when you can be discharged. Before you leave, the nursing staff will ensure you've got all your correct medication, but we'll go through your pain relief and your blood thinning products. Dressings, we'll make sure you've got a letter to give to the district nurse when they visit. And then you'll normally have an appointment between 6 and 8 weeks after surgery to see the consultant. Pain relief after surgery can be provided in different ways. We use tablets, capsules and liquids. It's different for everybody. We all feel pain in different ways. Some people don't have any pain following surgery and others do, so we can never tell. But there are a lot of medications that we can give. We also do a drug round 4 times a day on the ward. At each one you'll be offered pain relief. Please take it, because if you're in too much discomfort, you're not going to want to do your exercises, which will slow down your recovery. Apart from the 4 times a day that we come around with the medicines, you can also have medication for breakthrough pain. So in between those 4 times, you can also have pain relief. So just ask the staff. We also use non-drug treatments, something just as simple as repositioning, because you start to feel a little bit stiff. Ice packs are excellent. We use them for knees especially, but there's no reason why you can't put an ice pack against your hip area. And it just cools the hip down or the knee and helps to reduce any swelling and bruising. So the key points to remember, like I said, bring 1 box of each of your medications in with you, so we know that they are your tablets. Please don't use pill pots that we normally use, because we have to identify the drug, the dose, that they're in date, and they are actually yours. You can bring electronic equipment with you, such as a phone or an iPad. If you're having a spinal anaesthetic, you can take a radio device into the theatre with you, so you can listen to your own music if you so choose. Visiting is in line with hospital policy and is also at the discretion of the ward sister, and you'll be given the phone number for them in your paperwork. Try not to worry. All of the staff have been around for a long time, looked after an awful lot of people having hip and knee replacement surgery, and they're there to support and to guide you through your recovery. And if there's any concerns at all, that can be addressed, and the phone numbers will be in your information packs. Thank you.
Hi, my name is Phyllis Hughes. I'm Orthopaedic Discharge Support District Nurse. So I'm here just to give you a little bit of information about the service that we run alongside the orthopaedic team here at the Wrexham Miler. We're actually district nurses, but we cover Wrexham and Flintshire. We're based at Wrexham Miler Hospital, and we work through Monday to Friday. But in saying that, you do have covered 24 hours, 7 days a week because of the district nurse service that's out in the community. So if I was to have any issues, or you were to have any issues, we would have a contact number that you could ring to get support over the weekend. Contact details are on the screen, but you don't need to worry about writing those down. We will give you those on a little leaflet once you're being discharged from the hospital. Now, what's our role? We're here to provide ongoing care following your admission from the acute into the community setting. A few years ago, you'd have probably been in for over a week. Before that, maybe even 2 weeks, but now you're in and out in 1 to 3 days. So it's very important that you have that care in the community once you're discharged. When we come and visit you at home, we carry our own sanitising equipment, so you don't need to worry about providing anything. Now, we work alongside the multidisciplinary team, so we're here to liaise with physios, OT, your consultant, the ward staff, just to make sure that everyone's aware and we can continue that link from the acute into the community. We also carry out clinical procedures. That sounds very dramatic, but it's basically looking after you once you discharge. Your wound care, any bloods that need doing, anything clinical, we'll do that in the comfort of your own home. And the big thing we do is provide support and advice. You will get a lot of information thrown at you today when you come in. Seeing a lot of different people, and it's really important that you get some of that information and retain it. But if you don't, you have a contact number that you can give a call to and just get that information reinforced. So we're there at the end of the phone. So a little slide shows you that we try and provide a seamless service. It doesn't always work out. Sometimes we have little hiccups, as you can see with this slide, but generally they're only very small things and we get over them quite quickly. So how do we do that? We'll see you in joint school. We have a chat, we go through things with you, you meet the team, and then we come along and see you on the ward once you're admitted. Usually before you have your surgery in the morning, and then we'll see you after your surgeries. Now, you're a very important member of the team, so your role within the team is to ensure that we have an accurate address. And you'd be surprised, you might think, an accurate address, but you'd be surprised at the number of people that have moved house and not changed the details. Or it could be that you're actually staying with someone else on your discharge, a family member or friend. If it's within our catchment area, Wrexham and Flintshire, that's not a problem, we'll still come and see you. But if you're actually staying outside our catchment area, say in Cheshire, you would need to register with that person's GP. So the district nurses within that team would be able to follow up with your care. Please give us any directions if you've got a lovely house name, but it's up a lane and down a road and very difficult to find. But you can do that when we come and see you on the ward. And also we'll ring you on the morning of the first visit. We just ring, say hello, reintroduce ourselves, and it could be that maybe you've forgotten your dressing gown or a charger of some sort for your phone or your razor. That's your opportunity to say, well, actually, listen, Phyllis, I forgot this, it's on the ward, and we'll bring it with us whenever we come to see you. Concerns with visiting is usually things like if it's knees, maybe you have a physio appointment that's going to clash with when we're visiting. I've had one of those today. Person's going in the afternoon, so I go and see them in the morning. And it could be that you have maybe a couple of dogs that need sort of putting out of the room because they're not happy with people coming into the home. So we would ring you and let you know when we're coming, so as you can arrange that. So anything at all, any concerns with visiting, if you let us know, then we're aware of it and everything then goes smoothly. Now, this little slide is telling you about Clexane. Clexane, what is it? It's an anti-coag that's administered via an injection. Anybody that's having orthopaedic surgery or abdominal surgery, and it makes you less mobile than what you would normally be, then they have to have some sort of anti-coag. Consultants prescribe different things, and everybody's an individual, and it depends on what their medical history is. Some people have a little tablet that they take twice a day. It really does depend, and some people are already on warfarin, so everybody's different. But if you're prescribed Clexane, then what we'll do is we teach you how to do that yourself. So you get an opportunity on the ward to practice that prior to your discharge, and we support you with that at home. Now, if you have got Clexane, we tell you that it's only administered in the tummy. It's not licensed for the arm or the hip or anywhere, so it's only in the abdomen area, and you need to alternate sides. Left side one day, right side the next. So you need to watch out for things like bruising because it is thinning your blood. So if you were peeling potatoes and cut yourself, it would bleed a bit more readily than it would normally. So you'd have to apply pressure for a little bit longer. And we say to you, make a note of your injection site because, you do it on the left side and then you go to bed, get up the next day and you think, where did I do my injection yesterday? So it's important that you make a note on your calendar, one, that you've actually done it, and two, which side. So you can tick it off every day and you know that you've actually completed that. We also give you a yellow box home with you, which is a Sharps box. And that in Flintshire area, they're picked up. We give you a number to ring. And in Wrexham, we say drop it off at your local district nurse clinic. Again, any concerns with that, just give us a ring and we'll keep you straight. Now, finally, it's just a conclusion, really. Feedback's very, very important. This service has been running for quite a long time. It's important that if there's any concerns or if there's any questions, it's lovely to get good feedback, but if you have any concerns, then we look at those as well and we can actually improve our service accordingly. So thank you very much for listening. I look forward to seeing you all when you come in for your surgery.
Hi, my name is Cindy and I'm one of the physios that work here at the Wrexham Hospital. Following your surgery, you'll be seen by one of the inpatient physiotherapists who will guide you through your inpatient stay. The role of the physio following your joint replacement will be to educate you about your surgery, to provide you with an individualised exercise programme, to provide you with an appropriate walking aid, and to practice mobilising with that walking aid so that we can return you to early independence. On the day of your surgery, you'll be admitted to the orthopaedic unit. We'll reinforce the information we're telling you in this video. We'll check your exercises and you're happy with them. We'll assess your mobility with an appropriate walking aid. and we'll practice the stairs or a step if appropriate. On the day of your surgery, you will sit out in the chair approximately 4 hours following your operation. You'll start to mobilise with an appropriate walking aid, and you shall start your exercise programme. The exercises are aimed at improving circulation, to improve your range of movement, and to work on strength around your hip. On subsequent days, we will progress your mobility with your walking aid. Initially that will be with a Zimmer frame and progress you onto crutches. We'll continue with the exercise programme and we'll practice the stairs or a step if indicated. Milestones for your discharge from a physio point of view are that you need to be independent with your walking aid. You need to be able to get on and off the chairs independently, and you need to be able to negotiate the stairs or steps safely.
Hi, my name's Nicola. I'm one of the occupational therapists at Wrexham Hospital. I'm going to do a presentation just to talk to you about your total hip replacement and what to expect from an occupational therapy point of view. So the role of the occupational therapist is to look at activities of daily living, how you manage things like washing, dressing, your meals, how you're going to manage to get on and off the bed, chair, toilet, and will ensure that you have all the equipment that you need to assist you with being as independent as possible. If you live in the Wrexham or Flintshire area, we will try our best to come out and see you to do a pre-op home assessment. If you live out of area or we're unable to come and do the assessment at home, then we will go through everything with you in hospital. So it'll be asking you questions about home environment, what social support you have, and we can then arrange appropriate equipment. If we're unable to get out to you, we would ask you to bring in some measurements. So that would be measuring your chair, your bed and your toilet, just so it can help us determine what equipment you'll need. So there are hip precautions that we'd like for you to be aware of. It's important not to make certain movements after surgery as there is a risk of dislocation. To reduce this risk, you should adhere to the following precautions for 3 months. This will allow you to safely carry out tasks independently at home. So we do not want you to bend your hip more than 90 degrees. In the first picture you can see that somebody is sat on something which is too low for them, as their knee is higher than their hip. The second photograph is a better seated position because their hip is slightly higher than their knee. We don't want you to be bending down to the floor, so we will be providing you with some long-handled equipment that can help you with this. We do not want you to swivel or twist on your operated hip, so we'd advise you to take little steps around rather than twisting on that hip joint. Do not combine hip flexion, adduction and internal rotation. Ask your occupational therapist or physiotherapist to demonstrate this movement to you. You are able to sleep on your back, your operated hip or your unoperated hip. If you find it more comfortable lying on your unoperated side, we would ask you to place a cushion in between your legs so that your leg does not drop across the body and pull on that hip joint. Once you are up and about with physio and you're mobilising on the ward, an occupational therapist will come and see you. We will assess your transfers, so make sure that you're able to get on and off the bed, chair and the toilet safely, and we will assess you with any equipment. If we do issue equipment to you, we may ask if family can take this home from the ward if you haven't already had it delivered already. Washing and dressing after surgery. We do not want you to use the bath. If you do not have a shower, then we would advise for you to have a strip wash at the sink, and we can provide equipment support with this. You are able to have a shower after surgery, providing you've got a waterproof dressing. So we'd ask you to check with the nursing staff before you leave the ward that it's the waterproof dressing you have. We'd encourage you to sit down on a suitable height bed or chair and dress the operated leg first. We will provide you with a helping hand, so that can help with lower half dressing. You'll have a sock aid that can assist you to get your socks on and off without bending forwards, and also a long handled shoe horn which will assist with getting your shoes and your slippers on and off. We ask that you bring in some good footwear, just something with a supportive back so you can mobilise safely on the ward. So driving after surgery, we ask that you check with your consultant and let your insurance company know. The main stipulation is that you must be able to do an emergency stop, so that's getting full force of both feet down onto the pedals. Some advice for returning home: we'd advise you to remove any loose rugs and matting, ensure that there are no trailing cables to reduce any risk of falls or trips. Consider having a nightlight next to your bed to make your way to the toilet safely during the night. And we would suggest to place frequently used items that might be in high cupboards or low cupboards, bring them up to an easier working level so that you do not do any unnecessary bending or twisting.
Thank you for watching our videos about your stay for your operation. We hope to welcome you to the department very soon.